Welcome, everyone. My name is Tim Henry, and I'm a director of the Lindner Center and at Christ Hospital in Cincinnati. And I was president of SCAI in 2021 and 2022. And I'm delighted tonight to bring the second in our series of Pioneers in Interventional Cardiology. And certainly it's my distinct honor and privilege because we're going to talk tonight about the development of primary PCI. And from my perspective, I don't know if there's a more impactful development in interventional cardiology. We've made an amazing difference. And I have the privilege tonight to interview Bill O'Neill from Detroit and Cindy Grines, now from Atlanta, who clearly are qualify as pioneers in the development of primary PCI. So we're going to hear about that tonight. Bill, in 1988, ISIS-2 was published, and that's less than 25 years ago. And we thought it was ethical to randomize patients. One of the arms in ISIS-2 was placebo.
Right.
So really, when I was training, we treated STEMI with placebo. And you've been there since the beginning. Can you start and tell us a little bit about that journey and some good memories from there?
Yeah, so even before that, when I was in 11th grade, I was playing football. So I was out in the practice field, and my coach called me over and said, Bill, you're going to have to go to the hospital. Your dad's having a heart attack. And as an 11th grader, I had no clue what that meant. So I rushed over the hospital. It was close to the high school. And I got to the ER, and I saw my dad, ashen, pale, diaphoretic, in agony, and inside an oxygen tent, which is what they used at that time. This is 1967. And my mom was out of town. She was in Ecuador taking care of some business. Her father just died. So it was myself and my four younger siblings. And so all of a sudden, I had to be the adult in the room. And so I stayed with my dad for 2 nights straight. And a couple of times the nurses came rushing in, and it looked like he was going to die. And he said, Bill, I'm going to die. And that was my first intro to acute myocardial infarction. Subsequently, he lived for like 35 years, which is incredible, but had a massive inferolateral infarction, was in the hospital for 100 days. And the treatment then was just bed rest. He had an oxygen tent on for 2 months. And then he and my mom were talking about not having enough money because insurance ran out at 100 days. And then it's like, what are we going to do? He was a janitor and my mom was a seamstress, and we had no money. And there wasn't any kind of social safety net then. As an immigrant, it's like if you didn't have money, you didn't eat. So he went home. He became a cardiac cripple for a while. My brother Al and I, we had a 2-story home, and we carried him upstairs. He and I would carry him upstairs to bed every night and bring him down in the morning for almost 4 months. Because at that time, that's all you could do is like bed rest and hopefully survive. And so that kind of stuck with me. I kind of forgot about it for 20 years. And then fortunately, I was at the University of Michigan as a first-year fellow when we started doing our first intracoronary streptokinase trial. And again, I'll never forget that first patient. He was 39 years old. He came into the ER, had a VF arrest, resuscitated promptly, had ST elevation and inferior leads. And when we took him to the Cath lab, he looked just like my dad. He looked exactly like my dad had looked, because he was 39 at the time when he was 49 when he had his first infarct. Anyway, so we took him to the Cath lab. We did a cut down, Tim, a brachial cut down. I don't know if you ever did those, but that's how we did Caths at the time. Put a Sones catheter in his right coronary artery, did an injection. The artery was occluded. And then we started dripping streptokinase. And about 30 minutes into it, he started looking better. The pain resolved, all the diaphoresis and everything got better. And he had a short burst of VTAC. He said, what the hell, what's going on? So we were like freaked. And so we did an angiogram, and the artery was open. And it's like, wait a minute, it was closed before the artery's open. This is like, oh my God. It wasn't just the opening, it was how he responded to it. I said, holy crap, this is like incredible. And that was like May of 1980 was the first patient that I actually helped treat with the streptokinase. So that therapy was really pioneering. It was a breakthrough. the state of ignorance that we had at the time was just profound. We didn't know whether the thrombus was the cause of the infarct or was a passive event, and there was a lot of controversy about that. That was settled by Mark DeWood, did some amazing studies in Spokane, Washington, that showed very, very early in acute infarction, the arteries are almost always totally occluded. And then within about 12 hours, they had spontaneous lysis. So that was like the first nidus. But we didn't know whether or not you needed to use aspirin therapy. I mean, what's the deal with aspirin? And we didn't know whether or not you could use heparin in addition to streptokinase, because you got a potent systemic thrombolytic drug. What's going to happen with the combination between heparin and streptokinase? And the one thing that we didn't know that was really probably most important is that the thrombolytic pathway is a huge activator of platelets. And so the patient sort of developed this sort of prothrombotic state when you started affecting the coronary arteries. Anyway, the streptokinase studies look good. We participated in the first placebo-controlled trial where we dripped streptokinase versus glucose for 45 minutes. And I was the fellow that followed the patients afterwards. And it was just apparent to me, just watching these patients, the patients that had open arteries just looked better, they seemed better. And ultimately, that was proven to be successful by the Western Washington study that was done by Ward Kennedy and his group that showed that 1-year survival was improved in a well-done randomized trial. So that was kind of the fundamental start. Very early, very soon after that, in the mid-'80s, the Italian investigators did IV streptokinase. We were using intracoronary, but that seemed impractical. So they started using IV, and that's okay. National study, mortality was reduced, and so that was kind of like the pivotal thrombolytic trial. Subsequent trials really demonstrated later that there was an improvement. But I was always struck with when we did the intracoronary trials that after the lytics, there was always a severe stenosis. The artery looked ragged, it looked thrombotic. And a lot of those patients re-occluded. And so at the same time that this was going on, angioplasty was starting. The NHLBI trial started in the late 70s, early 80s. And a pioneer, again, Jeff Hartzler in Mid-America in Kansas City, had the courage, wisdom, bravery, whatever you want to call it, to start doing angioplasty with these really horrible crude instruments. There were balloon catheters that weren't over the wire. There were fixed wire systems, and he started to get very good results with primary angioplasty. So I thought, okay, this may work. And we did the first randomized trial of angioplasty versus intracoronary streptokinase. That was the first one that was published in 1985. So we thought, okay, this is going to be very good. And then right when I was doing that primary angioplasty trial, this incredibly elegant Ohio State Buckeye fellow came to visit with us, and we recruited her to our Cath lab, which is Dr. Cindy Grines. So she was in right at the very beginning, just like I was, and sort of totally got involved and involved with our early trials. She went to Kentucky, started the CAMA trial, which is a wonderful trial that she did with regionalization of angioplasty. And then I was able to recruit her to come to Beaumont Hospital. And at that time, we had kind of started to launch a trial of IV lytics versus pure primary angioplasty without any lytics, the PAMI trial. And, that's, I think, part of the seminal trials that led us to where we are today. So maybe I could turn it over to my incredible colleague of over 40 years, who's been like a friend, colleague, just an absolute champion. And she can kind of tell you, I've been in a foxhole with her taking fire for 35 years. So I couldn't think of a better partner to take fire with. So Cindy, maybe you can kind of take it over when you were a fellow.
So Cindy, I it's amazing. I forgot that you went from Ohio State to Michigan. So another one of these Ohio State, Michigan then. But you've been there from the very beginning. And can you give us your thoughts about starting as a fellow and then developing the PAMI trials and all the incredible impact that you've had in the reperfusion?
Well, as a fellow, my job, of course, was to go in at 2 a.m. and sit there in the Cath lab because we had to do these 60-minute and 90-minute angiograms after thrombolytic therapy. And many of those failed, of course. And it was really striking that as soon as you did that 90-minute angiogram, within 1 or 2 minutes, you could have a wire and a balloon down that vessel to rescue them.
Mhm.
And so it was just shocking how quickly we could do the reperfusion therapy. But we found that when we're doing angioplasty in the setting of these thrombolytic drugs, as Bill mentioned, it could be a mess. The vessels can be clotting off. And we didn't know if it was because we weren't allowed to give aspirin with thrombolytic drugs. We weren't allowed to give more than 5,000 units of heparin. There is no such thing as an ACT. So we were just flying by the seat of our pants doing these rescue angioplasties. And so Bill implemented this trial looking at streptokinase with angioplasty versus primary angioplasty alone. And what he found is that the addition of thrombolytic therapy actually did not help at all. It didn't facilitate reperfusion or reduce reocclusion, but it just created a mess. There were many more complications, obviously groin complications, but also higher rates of reocclusion. And so that's what the stepping point, in my opinion, that led us to focus more on primary angioplasty. And so when we were trying to do our primary angioplasty trial, the PAMI trial, it was challenging. I mean, first of all, we had this multi-billion-dollar pharmaceutical industry who just was anti-Beaumont Hospital and anti-primary angioplasty. And we had a lot of our own colleagues that were anti-primary angioplasty. And I can't tell you the number of times that I heard, what you're doing is unethical. You're killing patients. You should be sued for doing this. You're zealots. You're crazy. And so this was happening, at the national meetings. And at the national meetings, back in the days, there was very adversarial. People would stand up and start shouting, very argumentative. And so, it was quite unsettling. But, the good thing about me is I was young and I was naive and I thought, well, this is just the way it is. I didn't take it personally and I wasn't intimidated by these people like Peter Slight or Eugene Brunwald, because I never met him before. I had no idea who they were. And so there's an advantage to being young and stupid, because it allowed us, Bill and I, to move forward. In my situation, it's, every time we were criticized, and I became more bold, and we're going to address this criticism. We're going to do the next trial, and then the next trial after that, and it just led to a series of trials addressing every one of our criticisms. And ultimately, as you know, primary angioplasty was the big winner.
You wrote the definitive paper.
Right.
That compared, thrombolysis to primary PCI. That probably is one of the most quoted papers of all time, don't you think?
Mm-hmm.
Oh, yeah, absolutely. I mean, that was pivotal. But I have to say that, we were convinced at that time, because primary angioplasty in a randomized comparison to TPA, we reduced reinfarction, we reduced, reocclusion rates, we were, reduced stroke, all stroke, hemorrhagic stroke, you name it. It was a lot higher survival rates. And so in addition, there had to be multiple other trials before we convinced the rest of the world. And so we led the way, but then there were a lot of followers who then reproduced our results. And it was the pooled comparison, the meta-analysis that Ellen Keeley and I did that finally proved that it wasn't just in the shadows of Beaumont Hospital. If you're having your heart attack, you can come to our Cath lab. But, we found that in many different settings, it could be performed. And this is proven in that randomized trials and the meta-analysis.
Back in the 90s, some of the criticism was, well, you can't do this everywhere. Maybe you can do it at Beaumont, but you can't do it in Timbuktu, and you can't do it in Canton. But that actually proved to be incorrect. And you can do that, and it's really amazing. I mean, Jeff Hartzler looked at an analysis, and he said that 65% of the U.S. population lives within a 30-minute drive of a PCI-capable hospital. So I think that part really needed to be proven. But the skepticism, it was just like almost irrational, the amount of skepticism that people had. It's just like, well, you can't do it, and there are not enough hospitals, and you bankrupt the system. But I mean, the thing that ultimately kind of reinvigorated my faith in U.S. scientific medicine was that once the data was conclusive, once Cindy published the meta-analysis, and once the DYNAMI trial was done, then I think the scientific community concluded, yes, this is a better approach. And then Alice Jacobs, who was the president of the American Heart Association, I think in around 204, 205, made it her mission to try to increase the number of STEMIs that were treated with angioplasty. And that's when they started to get with the guidelines and those programs really to try to expand. And so I think that the thing that is, to me, is just like incredible. I just can't believe in retrospect that now, if you come in anywhere in the country, really basically any city in the country with a STEMI, you're going to go to the Cath lab. You know, there's even a thought about doing primary thrombolytic therapy. So to me, it's like, okay, if we can prove the science, then everybody will get on board and we will systematize the care. It kind of goes towards the controversies that we're having right now about cardiogenic shock, because there still is, a lot of controversy about how to treat those patients. And I think that we're going to need to have many more randomized trials. But you were like super influential in my estimation in proving that this sort of therapy that was ivory tower kind of stuff could really go in the community and could expand and kind of in the shadows of the Mayo Clinic. You guys proved it right.
Mm-hmm.
Well, so I was one of those followers, Cindy, and it's really true. So in 2002, I went to the Minneapolis Heart Institute, and they went to like 25 or 35 communities throughout Minnesota, and the Dynamic 2 trial, which then was, okay, we had solved primary PCI, but what about all those people that are non-PCI hospitals? And the Dynamic 2 trial was kind of the definitive trial that showed that transfer for PCI was better than lytic 2. But Cindy actually started that with one of the PAMI trials. So you started, not only did right here on this night tonight, we have the start of streptokinase, the start of primary PCI, and the start of transfer for PCI.
Right. Exactly.
I had just lived through 10 years of listening to the battles, and I had this, I believe that transfer was the best way to go. And so when we put it in as a standardized protocol. And it's really interesting. The very first patient was actually the mayor of a small little town called Waconia, and it's about 40 miles from Minneapolis. And when we started, we actually gave lytics because we weren't sure how it would go. So this is a mayor who got streptokinase and got transferred. And my good friend Dave Larson, who was the ED doc who helped set it up, called and said, well, we're transferring. I happened to just be on call. And I said, well, okay. And it's an inferior infarct, right? And they transfer, it goes to the helicopter, goes to the roof, comes down. And the nurse who's working with me goes, Tim, he looks like bad word. And I said, well, come on, it's an inferior infarct. He already got lytics. Well, it turns out it was a left dominant circumflex.
Oh, wow.
And had not reperfused. So when he got to the Cath lab, his pressure was 65.
Oh.
And literally within 10 minutes, we had opened the artery, and he went from basically going to be in shock and die to he went home in 3 days with a normal ejection fraction. And sometimes these anecdotal things help because there was a little pushback. Well, can we really do this? It's a lot extra work. And then that opened the door. And so then we did it in one town, and then 3 other towns wanted to do it. And pretty soon we had a network of 35 plus hospitals. And from a 200-mile radius, we transferred people. And, Bill, just like what you said at the beginning, all I heard was can't be done, impossible, not possible in the United States. And then, and I'm like, well, it's working. And it was, I knew it was the right thing, but I had no idea how much really difference it would make. When you started on transferring, Cindy, that must have really been a big step out, right? Transferring people from a long ways away.
But that was one of the criticisms, is that it's not widely available to everybody. So we created the PAMI trial, which is a randomized trial in patients with STEMI who present at outside hospitals without a cath lab. They'd be randomized to receive on-site lytics versus being transferred for primary angioplasty. And they could go, we call it PAMI, but they went by air or by ambulance. And what we found in this randomized trial, and it was the first one, and it was a pretty big trial, and they were clinical results that were important. So despite an additional 120-minute delay in the transfer process, those patients did better. They had, once again, they had a lower mortality, they had reduced reinfarctions, they had the absence of strokes. And so, I think at the time it was considered heresy, but now it's very commonplace. So then we went.
Cindy, you did that trial in a shoestring. I mean, in terms
yeah.
of funding, it was just like it's just a lot of people that were just passionate about it because the amount of money we had for all of these angioplasty trials was just like really ridiculous. And I remember you telling me that you had problems with follow-up with one of the Argentinian sites. And so they actually had to send like a sheriff or something to go find a patient, and they had no address. So it's the second house from the tree across the creek kind of thing is how you found the patients to do the follow-up.
Oh, so yeah. It was crazy. And same thing when we had some patients enrolled in India. It was very, very difficult to get follow-ups. And we did. We had to send the investigators out to find them. So that was interesting. But then I wanted to comment that we moved on after PAMI. Then we did PAMI no SOS, no surgery on site. So our friend Tom Wharton, who was in New Hampshire, he was doing primary angioplasty at just a cath lab. There was no PCI, there was no surgical backup, and he was getting good results. So we did this. We took the high-risk patients, and in this registry, it was an independent registry that was all event adjudicated in a core lab. And we took all these hospitals that were doing angioplasty in those angiographic labs and enrolled 500 primary angioplasty patients. And what we found is that their outcomes were as good as Bill and mine. The core lab found the PCI results were just as good, and the clinical events committee found the outcomes were as good. And so it was interesting. We tend to think that, we're better than some of these other doctors, but that's not necessarily the case. But that, again, even though it was a registry, it was independently adjudicated, the first of its kind. And so that started spreading the angioplasty at hospitals while it's surgical backup.
So, it's amazing. You inspired me with PAMI and the results. And when we started our STEMI network, Dynamic 2 results weren't done. And they were published. They stopped the trial early because it confirmed that transfer was better. And that was published in 2003. And I have a letter. It's that maybe we can get a copy for everybody, but Henning Anderson sent a letter to me and said that he appreciated the STEMI network because whenever he went any place in the United States, people told him it couldn't be done. It could only be done in Denmark.
Yeah. And,
I think, Cindy, another thing, you and I with Samir Mehta had the, Lumen Global program where we then had the privilege and opportunity, all three of us, to go around the world and help develop STEMI networks. It's just shocking how much different we've made in patients.
So Tim, the other thing we can talk about is how we switched from angioplasty to stents.
Yeah.
Because if you remember, in the late 90s, there was still a huge worry about stent thrombosis and you give Coumadin or not. And I mean, it was just a mess when we started doing that. We put the patients on dextran and heparin, and we pull the sheets on fully anticoagulated patients. I mean, it was just, so then how can you do that in a patient with acute MI, which is like an absolutely thrombotic laden environment. So we actually did a study. It was a really interesting trial. Johnson & Johnson developed a stent that was heparin coated, a HepaCoat. And Cindy actually led that trial. And that was the first drug coated trial that was ever done with stents. And the results looked really pretty good. But they decided not to pursue it for whatever reasons. And it was really a good stent, a very low risk of thrombosis. But when we did our first trial, the results were just kind of marginal. I really wasn't that convinced that stenting was that much better. But ultimately, there was less TVR and target vessel failure. And so that it did impact on restenosis. So it
Right.
was very daring, I think, maybe really kind of not foolish, but foolhardy to try to start doing it. But we did, and it worked very effectively. Cindy, I wonder if you can comment about that in terms of like, the push to do stenting in these patients.
Well, I think one of the problems with just doing balloon angioplasty is we did have a high reocclusion rate. Now, it wasn't as high as with TPA, but patients would have elastic recoil and dissections, and we didn't really know how to manage that. And so when this heparin-coated stent was available, of course, we wanted to test it. And this was a bulky pulmonary shot stent, if you remember. It was not one of these flexible stents. And so the downside to using this stent is that there was a trend for higher rates of no reflow. And that was the first time that, we hypothesized that that soft thrombus was potentially breaking off and going downstream. But despite that, the patients did pretty well, and they had a marked reduction in recurrent ischemia and reocclusion and target vessel revascularization. And it was a big trial. It was over 900 patients that were randomized. So it was balloon angioplasty versus stenting. And the first stent done in acute MI and the first drug-coated stent used as well.
Yeah, I think another one, I remember Dextran myself. It was a nightmare. And, one other thing, I think, lots of things have contributed as we've improved reperfusion, but I think development of Plavix and P2I212 inhibitors has shockingly, because, the key part of when you started with the why do we have an MI and platelets, it became clear platelets were a really part. And so, lots of things have taken us from here to there. But it's amazing that this has happened in 25 years, really, right? It's like gone from no treatment. And that was an amazing story about your dad, Bill. Just like a remarkable story. I had a similar when my grandfather died when I was a sophomore in high school from an MI. And you realize he wouldn't now, right? And now we go from and another thing Cindy pioneered was early discharge.
Yeah, right. Yeah, I was so struck by your description of your dad, Bill, because remember our PAMI 2 trial.
Totally.
So we separated patients into high risk versus low risk. And the low risk patients, we randomized them to an early discharge strategy versus conventional care. So at the time we found that, from PAMI 1, we found our patients were doing really well. They didn't really have that many complications. So why should they stay in the CCU forever? Why should they stay on the floor? Why do they need to, get a pre-discharge, all this non-invasive testing and treadmills, which is what we used to do, right? So what we did is we randomized these low-risk patients to a 3-day hospital stay, skipping the ICU. They went right to the step-down unit versus the conventional care where you would keep them in for a week or whatever. And of course, the patients who are low risk, they did fine, and we saved a lot of money. And so that was, again, leading up to what we're doing now. So a big difference between, 4 months of bed rest versus kicking them out the door in 3 days. And then the high risk, the patients who are high risk, we had randomized them to receive, after reperfusion therapy, they were receiving a balloon pump versus no balloon pump. And what we found is that the balloon pump really had no added benefit. It did not reduce reocclusion. It did not further improve LV function. There was a tendency for higher rates of stroke. And so we really did not advocate using balloon pumps in high-risk patients. And I think that subsequent trials have shown the same thing.
So, Tim, I have an interesting anecdote to sort of share with the group. In the mid-50s, there was an autopsy study done in a psychiatric unit and for people that died suddenly. And there was a substantial incidence of ruptured myocardium that caused the death. And so the feeling was that the psychiatric patients really didn't know what was going on and couldn't say that they're having chest pain, really didn't understand it, and they were let ambulating. So because of that, the dogma in the 60s and 70s that the patients had to be under strict bed rest to allow the heart to heal. Dwight Eisenhower had a massive infarct in 55, and he was kept in the hospital from September through December on strict bed rest. So, so thinking about early ambulation and early stress testing and early discharge was just absolutely, counter to anything that we've done in 40 years of medicine. So, but it was proven with good data that you could safely do it. But how we've changed the care of MIs since the mid 70s to now, it's just absolutely unbelievable. The disease has kind of become totally different now, and the outcomes have been just so good compared to where we started from.
Well, and one of the things that is clear, Bill, when you listen to this, it was the advances were made on observation, but the field advanced because it was really well done clinical trials.
Right.
I mean, in each one of these areas we talked about, it wasn't just, oh, I'm going to do this. It was like, okay, let's keep track of it. And I think really in cardiology, that's been remarkable. And the two of you were clearly leaders in pushing, putting patients in clinical trials, following them up. And it's made all the difference. I mean, we think now, we put in an early discharge based on the Zwolli score, right? And so the goal was if you had a low Zwolli score, that you did not have to go to the ICU and you would be discharged within 48 hours. And it turns out that's 65% of the patients. Well,
Right.
The very next week we put it in place, and then I came to see someone who had come in at 10 o'clock the last night. It was about 10 o'clock in the morning, and they'd already discharged. I'm like, hold on.
Outpatient primary angioplasty.
Yeah. So I mean, that's what that's where it's really become. And now we have, the Denmark group published in JACC this ongoing improvement in mortality, and really done on a system-wide approach. You have mortality rates less than 5%. So what are the challenges going forward? Where do we need to go, Bill? Where do we need to go next? In particular, cardiogenic shock.
Well, before that, I think that and some of it is a little blissful ignorance. Patients with anterior MI still, although the arteries are reperfused, they still end up, a substantial number of those patients still end up with a huge infarct. And we've all seen these young patients that, come in early, open up the artery, and then at the time of discharge, they got a huge akinetic anterior wall. So we've been trying for almost 30 years to try to decrease infarct size. And that, I think, still is a huge challenge. We've just finished the STEMI D2 trial. It's going to be done at the end of the month, and we'll see whether or not unloading with Impella decreases infarct size. So I think that still is an ongoing challenge. And then with cardiogenic shock, and for me, the lessons as we're talking about all of this is that the doctors have a little bit of a conflict of interest because they want to be scientists, but they're also physicians. And so when you're looking at the patient eyeball to eyeball and saying, okay, this is the study that we want to do, if there's any lack of equipoise, then it's going to be difficult to randomize. And so what we did in all these trials is we started with one therapy. First, we started with intracoronary streptokinase compared to placebo. That was good. And then we compared intracoronary streptokinase to angioplasty. And then we compared intravenous thrombolytics to angioplasty. So there was always sort of an active treatment, so the doctor wouldn't have to worry about not giving their patient any therapy. And that's, I think, why we were so successful and were able to so rapidly recruit in many of these trials. So I think you have to be very careful about designing trials, especially in cardiogenic shock, because those patients are so incredibly ill. So that if there's a lack of equipoise, then the doctors won't randomize the patients. But I'm completely convinced that we have to do further randomized trials in shock. But I think now with the danger trial results coming out, I think that gives us a lot of optimism. And I think we're going to see a whole series of trials going down the road to improve the outcome. Still in danger, the mortality at 6 months was 50%. So we're still 1 out of 2 patients in acute MI shock are dying within 6 months. So there's an enormous amount of room to go with that field. I think enormous amount of challenge.
Yeah, I think your point about microvascular obstruction is another really important point. And I think, we have a whole series of trials preclinical that are positive, and then we get to people and they're negative. But that's because we put 100 patients in the trial, but 40 of them are normal.
Right.
And so I think one really important next step is to be able to identify microvascular obstruction immediately, and then you target. I've been a little disappointed with the uptake of supersaturated oxygen,
Yeah.
for
Yeah.
example, because
Yeah.
it is a little more work. It takes a little time, but if we could target it to the high risk patients, it might be better.
Mhm. And also, I mean, there isn't really a true survival benefit that's been scientifically established. There is a dramatic reduction of infarct size, but I think that what they need to do, and they're going to be doing this with larger trials. A trial is just going to start now with a comparison of 500 patients with anterior STEMI compared to supersaturated oxygen, to looking at outcomes and improvements in ejection fraction. And when I look at the kind of anecdotal data, the ejection fraction increases with supersaturated oxygen look really good. So again, I think that's an area of promise.
Yeah. So Cindy, where do you think we need to go next? What's left to be done?
Well, I think that there's also concerns that I have about post-discharge. So if you look at the STEMI mortality after primary PCI, the in-hospital mortality is 2%, right? But then once they've sent home, the follow-up mortality is another 2%. So what is happening to those patients? I think we need to get a better handle on that. I mean, we clearly have, better antiplatelet agents, and now we have better lipid lowering agents. So perhaps that additional mortality will get better over time, but it's really disappointing because, as an interventional cardiologist, I would have thought, well, we saved their life in the hospital, so they're home free, but that's not the case. So additional follow-up, additional medical therapies.
Well, I think for everybody listening out here tonight, you see that, first of all, I always say about both of you, I loved and admired you before I even met you both. And it was like, I remember meeting you, and it was like, really so impactful for me. And like, for people listening, it's just absolutely remarkable over the last really almost 85, so almost 40 years that we've been working on this. Then, and the two of you have been involved in every aspect of improving STEMI care. And so thank you.
Thank you.
We're delighted to, honored to talk with you tonight. You're our hero too.
All right, Cindy,
Absolutely,
any
Tim.
final thoughts?
No, I think we've covered it all, but I think just emphasizing how difficult it was to get these trials off the ground, how we had no research funding, and it's the goodness of the hearts of all these other investigators that they would do these projects for free. One concern that I have is that it's so driven by industry now, and a lot of more rules and regulations and corporate compliance, and it's much harder. You wouldn't be able to do these kind of trials today. So we are fortunate to be in that era, Bill, where we could accomplish a lot of wild ideas that people may not be able to do today. But look what a difference it made.
Well, even and a perfect example of that, Cindy, is we were all three of us involved in so many trials where there was almost no funding. People did it goodness of their heart. And that even just went, the most recent one was COVID. And we had the North American COVID MI registry. And so we ended up having 800 patients who had COVID and it was a very different kind of STEMI, right? More patients had non-obstructive disease, and patients had microvascular thrombi. So, I agree with you. I think there's a lot of people that really goodness of their heart trying to make care better. And so clearly, this pathway of reperfusion therapy is one of the most impactful things for sure that has ever occurred in interventional cardiology and continues to occur. Bill, final thoughts?
No, I think we always have to keep the patient in mind first. I mean, whenever I got up at 2 a.m. to get a STEMI call, it's like, okay, that could be my dad. It could have been my dad and or one of my families. So I think most doctors that do primary PCI, that ends up being probably the most gratifying and fulfilling professional work you can possibly do. And seeing the patient's family afterwards and the joy when you tell them, okay, we got the artery open, he's going to do okay. has just driven us. And I would really encourage the younger people really to think about that when you're going in. You got all the crap that you're doing and all the charts that you have to review and all the compliance stuff. But at the end of the day, you're eyeball to eyeball with these patients, and what you do for them will impact the rest of their lives. And do it well, and they'll have a good outcome. And you can't have anything more professionally gratifying. I'm just absolutely thrilled beyond belief to be so lucky to have been an interventional cardiologist during this era.
Well, I don't think you can sum it up any better than that.
Mhm.
So, Bill, thank you. Cindy, thank you. This is a remarkable night. I loved it, and I hope that all of you out there watching enjoyed it as well.